Record. Okay, great. Good morning, everyone. My name is Jackie Klotz, and I want to welcome you to our webinar with William Lyons from Legacy Community Health and Felicia Latson, who is formerly with Legacy Health, now with the Women's Home, who will talk to us about evaluation to guide NMDOH programmatic adjustment. This meeting will be recorded and shared on your YouTube channel after the event. We will also email you a copy of today's slides for your reference. We want to know who's with us today, so please introduce yourself in the chat box. In addition, there will be time after today's presentation to answer any questions you may have. As those questions arise, please post them in the chat and we will monitor them. To kick things off, I'd like to pass the mic over to Jessica Pugel to introduce the session and speakers. Jessica is a leading evaluator in the NMDOH space as founding principal of Working Partner LLC, where she is a skilled empowerment evaluator with over 25 years experience evaluating large, complex, multi-site initiatives. Over to you, Jessica.
Great. Thanks so much, Jackie, and welcome to everybody. We're so excited to have you all here. And extra stars to all those people in Houston who are still without power. It's a long time without power, and that can be hard. So thanks everybody for joining. So I see the people who are on this conversation with us today, and I know that all of you really understand the importance and the value of evaluation. And what we're going to do today is talk about the role that evaluation plays in sort of the formative role in understanding how a program is working, if it's not working the way that it's intended, how we can make it to work it better. And so we're very excited to have William Lyons and from Legacy, and Felicia Latson, who is by day the amazing director of programs. No, what is your title at the Women's Home? I don't know what your title is.
President of Community Wellness.
Vice President at the Women's Home, who is also doing great work. But here she's in her role as the founding principal of Swalis Advisory. But Felicia brings a lot of knowledge about Legacy. She was the senior director of programs of SDOH at Legacy. And so together, she and William are going to talk about the Bike RX program and the food program that they have at Legacy. So there are stars for today. So I'm going to turn it over to them to get started. Just a couple things. We do want to have this as a conversation, but we're going to leave all the questions to the end. But if you have a question or an idea that you want to talk about, please do put it in the chat throughout the conversation. We'll make note of those and come back to them when we're into the Q&A section. So with no further ado, William and Felicia, take it away.
Great, thank you. I'll get us shared here. Is everyone seeing a full presentation screen?
Yes.
Okay, great.
So we just first wanted to thank everyone for making time today. Again, we know those of us who've been in Houston more than 6 years, we've had hurricanes before yet, and each time it is that much sometimes harder to build back better. So I definitely appreciate people showing up today and listening to what we have to present on. Next slide. We first wanted to start off with a little bit about Legacy. So we are a federally qualified health center. For those who maybe were on a little early, we have been impacted by Beryl. For 5 to 7 of our clinics are still closed. We're in 2 of them are one of our larger clinics, so we definitely impacted by it, and so we're hoping that they will reopen soon. We've been around for about 40 plus years. We offer all the primary care, especially care services, also have pharmacy services as well. We're the largest FQHC in our region. And we ensure that our programs and services are available to patients irregardless of the ability to pay. And with that, I turn over to Felicia.
So I'll kick us off and talk about our Bike RX program and how it came to fruition. This is really a labor of love of of myself and several organizations, but it didn't necessarily start with us. It sort of started just by happen chance. Apparently, the city of Houston Bike Share, and Legacy were already in discussions about how to bring more B-cycle stations to the Fifth Ward community. And Legacy has a large flagship building right on the main corridor in Fifth Ward. And so there were already discussions on just the infrastructure side on how a station could be placed in front of the clinic, since it is in such a visible location. But myself just living in the community, and also being a social worker in the community at the time, I was privy to community groups and working with other stakeholders in other projects that then brought this conversation to light and made some light bulbs go off about like, oh, well, if you build it, you can't just expect people to use it, and you can't just expect people to come and take part of this. You actually need to have some programming and some community engagement around it. And so American Heart Association was instrumental in that conversation and bringing all these parts together. And so because we were already working on some COVID response initiatives together and doing some food distributions, that's how we decided to continue to work together and push this Bike RX, well, what became to be known as Bike RX program along. So like I said, the city of Houston, Houston Bike Share, Legacy, they were already having some initial conversations just about, well, how, where on the sidewalk do we break up the concrete and put this station? That was happening separately. American Heart Association and our team, Health Connect, we were already doing some other programming, and then we decided to bring all that conversation together and figure out how we make this something sustainable and useful for the program. So that came about in 2020. As time went on, by summer 2021, another community agency, grassroots community agency, Our African Family, were already starting to host community or bike rides for the community. They had also been engaged with Houston Bike Share to be able to get bikes to be brought to the community even before stations were built out, and there was just a set of stations available for people to rent from. They'd already engaged Houston Bike Share to deliver those bikes to the community on the day of the bike rides, and be able to have people to ride for free. And so again, me being a social worker that lived in the community and that worked in the community, I was able to sort of play that dual role of things that I was doing in my volunteer life anyway, to also complement what was happening on the formal side in my professional life. And so those bike rides were great, and they were moving along, and we as Legacy tried to come in and just be a support to what the community was already doing for its own resilience. And we continued to formalize what we needed to do as far as the organization that could do the medical piece. And so our way of supporting that work was to give a prescription so that more people who didn't necessarily just live in the Fifth Ward community could also be able to access free bike rides. And that was how the Bike RX program came to be about. So around fall of 2021, we started to host focus groups with both our physicians that worked in the Legacy Lions Clinic and those patients that lived in or around the community that could benefit from this program. And so based on their feedback, we really started to shape how we would implement this program and how we would, how much access we would give, and the things that we could start to evaluate. And finally, in spring of 2022, we were able to launch and host a ribbon cutting and groundbreaking for the station that was put there, and hopefully that clients would start to be able to use. And so I just want to highlight some things that came out of the focus groups that we had with potential participants. We wanted to evaluate what their pre-existing beliefs about biking as it related to their health and safety. We wanted to understand their baseline level of bike knowledge, and what barriers to biking that they may perceive for themselves. And so we try to garner participation or increase participation in those focus groups by also offering some type of incentive for attending. And just to be honest, you'll hear me be very transparent, and both William and I be very transparent in this presentation. Not everything that we did worked. Not every idea was a great idea. So even though we had that incentive to have people come out to or have people attend to the focus groups, they were hosted on Zoom, so people didn't have to travel. The turnout was still sometimes low on those focus groups, but it's still important to do that as far as the community engagement piece, because regardless if you have 2 people or 5 people show up to your focus groups, when you're working in communities that have been marginalized, it's important to realize that those people can still be your amplifiers, and they will go out and talk to other people in the community. So don't always just focus on, well, only 5 people logged onto my Zoom, or only 2 people came to my in-person meeting. The community will talk and spread the message if it's something that you're doing well. Sorry, trying to go forward. Okay. So after we engaged a lot of people and went into a lot of discussions, we decided to focus on the age range of 18 and over. And that was chosen because that's the minimum age that B-Cycle can support. They can't enroll children or actually give an account to children. So you do have to be an adult to have a Houston B-Cycle account. We decided to focus on blood pressure and A1C ranges, A1C being a measure of someone's blood sugar at the time. It's just a kind of a point in time count blood sugar is a point in time count. A1C is a more of a global measurement of someone's diabetic or pre-diabetic state. And so we decided to focus on numbers or metrics that were pre-disease state, because we didn't want this to just be an intervention that people can receive once they were already in the disease state. We really wanted to take a population health approach, public health approach, and intervene prior to people becoming diagnosed with an illness. So that's why you'll see us intervening or making the level for entry available to anyone, basically, that was healthy enough to exercise. And so we had this idea that we really wanted to make this a prescription from a doctor. And we wanted the providers to be driving and be the entry point into this program. So and be able to evaluate whether or not patients took advantage of this program because it was their doctor telling them to do it and prescribing it just the same way that they would prescribe amlodipine or any type of diabetes and medication or intervention. And so that prescription could come in the form of a physical card, and it would also be an e-referral through our electronic health record at the time. And so the patients were enrolled through a health advocate, and that's a program that William will talk about later. But we basically had health advocates stationed in the lobby of the clinic. And so in theory, a patient would take this prescription that they just got from their doctor, and they would go over to the table where the health advocate was sitting and redeem their prescription. And that health advocate would take them through the basics of the enrollment process, give them a key fob that they would use to then check out bikes, walk them over to the bike station because it was at the clinic, it was just outside the door, show them how to scan the fob, check out the bike, and secure the bike back when they were done. They were also provided with helmets and safety guides that were provided from the American Heart Association. One of the enrollment criteria also was that the patient had to have a phone, and that's something that we just couldn't get around because B-Cycle or Houston Bike Share needed some kind of way to create an account for the person with the bicycle and be able to follow up in the event that the bicycle did not make it back to a station or it wasn't locked in properly. And so that's just not a barrier that we could have gotten around. We couldn't go out and give everybody phones if they didn't happen to have one. And I will point that if a person simply did not have enough bike skill to ride independently on Houston streets, if you're a biker, you sometimes know that can come with challenges. We did refer them to another outside partner at the Houston County or Harris County Precinct 1. They also have a bike lending program, and people could ride on the sidewalks of the precinct buildings, where it's a little bit more secure. They're at, staff on site so that if someone falls or gets hurt, hopefully some will see them and they're away from traffic. So we did try to create a pathway for people who were not at that stage of bike knowledge to be able to ride independently. So I'll toss it to William to talk about some of the evaluation points.
Thank you. So when we were thinking about, do we maintain this program or do we redistribute resources, we were thinking about enrollments, provider referrals, and utilization. One thing that we recognized that we did have low enrollment over the year and a half it was operational, our program. Part of that was related to provider engagement. So obviously, given the program was provider driven, we wanted providers to make said order, said request to the patient. If providers are not referring the patient, then we don't have patients enrolled. And from some of the conversations with providers, they just perceived that patients would not be interested in it. And so they weren't introducing it to the patient. And so I have my own kind of professional beliefs about that, given that sometimes people might say it's biased. Yet I also recognize that the providers also know their patient, and what happens in the exam room is should be honored. And so we took that feedback and just tried our best to continue to provide that information to providers about the research we had done from other programs across the United States where it did show success in that patient population. We did try to make it easier to refer. So we worked with our EMR system to create a referral button versus having to do any type of quick text or anything like that. So clicking the button to refer versus having to type up a order each time. We wanted to streamline the process a little better. We considered adjusting age, but B-Cycle reiterated at that point that they couldn't offer an account to anyone under 17, under 18. And so we had to, we couldn't really explore that fully. When we didn't engage with patients who were actively enrolled in the program, we kind of looked at the redemption from B-Cycle. They could let us know how many people actually used their fob to check out a bike, which was low. And so when we call patients to kind of ask about their low utilization, they kind of reference the heat a lot. And so just recognizing that, when you're exercising outside, heat can be definitely a deterring factor for someone of any age, but just recognizing that, particularly in Fifth Ward, that we don't have as much tree canopy in our region, and so it just gets hotter in our region than in other places. And the other thing I would say, the convenience as well. So though we also consider expanding it to other clinic sites. So this was a pilot at our Fifth Ward location, in part because it had a B-Cycle station in front of it. But then our other clinic locations, though they were interested, they don't have a B-Cycle station in front. So there was not an opportunity to engage the patient directly with checking out the bike, and at their convenience, they would have to have traveled to a B-Cycle station to check it out in their community. And we did try that mass enrollment event, yet we struggled to get patients to show up. And we did our last enrollment event around October of 2023. And I'll turn it back over to you, Felicia.
And just some other points to highlight. We chose, in the targets that we chose to try to evaluate, I'm sorry, I knew that was going to happen. I hope that noise is not too loud. It's going to stop. We chose an enrollment goal, or we had a target of enrolling at least 90, or I believe 75 patients in our first year. And we chose that goal based on our prior experience with our food prescription program, which we will talk about later. And so that was one evaluation point that we wanted to focus on, is how many people actually enrolled. We also wanted to see if or how many minutes per month or per day they were using the bike. We gave them access to be able to use the bike up to 90 minutes per day, because that's what B-Cycle's Go Pass program allowed for. So that was how we chose that evaluation point. We had the opportunity to partner with the university to do a more formal and more robust evaluation, to look at everything from changes in cholesterol to basically any health metric that you can pull out of the EHR. And we really gave some careful consideration to whether we wanted to bring research into this project from the onset. After some really deep consideration, we decided to not engage that university partner, even though it would have been amazing to have that type of detail on the back end. But given the timing that this program was coming about, this was summer 2021, spring 2022, there were several factors impacting our decision to not move forward. One, this was in the midst of like COVID vaccine, medical science research conversations, and distrust just in the general public. Also, our Health Connect program was built on our health advocates being able to engage clients in very sensitive conversations by using the statement, "Hi, I'm Janice. I work with your doctor, and your doctor would like to know X, Y, and Z about your health conditions and things that are happening at home. Can you have a conversation with me?" And so we felt like that relationship would have been hampered or somewhat ruptured if we then went on to say, like, "And also, will you sign these consents for us to share your information with, an outside entity or university partner?" It was almost asking for two things at the same time that didn't belong in the same box. And so we chose not to move forward with that. But if someone else wanted to move forward with replicating this project in any type of way, or with other partners, that is an opportunity that would be available, and we're happy to share which university partner would be beneficial to approach. So, as far as outcomes, I got a little bit ahead of myself, but sorry, all of this stuff is in my brain. So what went well is that we successfully advocated for a bike station to be placed at the Lions Clinic, because there were some other partners that were, also contending to be awarded this station. And so what that did was create a series of 4 bike stations within a 2.5-mile radius. And so having these 4 stations kind of in a line along Lyons Avenue created, in my brain, if this would have kept going, created the opportunity to really do some innovative type of partnering and linking with particular businesses, different community groups, and healthcare facilities. So there was a station, the first station kind of on the line was at a Metro hub or Metro Transit Center. And then there was another station at a community partner. And then the third station was at Legacy Lions. And then the fourth station was at St. Arnold's Brewery. And so had this continued to go, we could have done something where, okay, a person, regardless of where they're coming from, they can get dropped off at the Metro station, pick up their bike, do some engagement with a community partner, come to Legacy maybe for medical care or to just get any other kind of the services that we provide. And then maybe there, if there's some continued use, maybe there's an opportunity to do some type of incentive for dinner or healthy eating over at the St. Arnold's Brewery, because they sell more than just beer. They're really a good community partner. They're a brewery, but they sell more than just beer. And so, by having this set of stations in one place, that it provided for just some other type of creative collaboration. And we also had the chance to support a community organization that was already practicing their own resilience. And that's the way that bigger institutions and entities with more power, that's really what we should be doing, right? We don't always have to be the one that get the credit. And I'm saying we as a bigger institution, we don't always have to be the one to get the credit and say that we are doing the thing. We can be a powerful source by being in the background and helping people do for themselves without us ever being seen. And so, when grant funding comes along and all these other opportunities, and we're looking to partner, we can be intentional about who we put on the forefront and highlighting what communities are already doing for themselves. And so we also did a good job in figuring out a way that providers could actually prescribe something that was other than medication. That's not something that's really been tried out before, or that a lot of infrastructure has been put around. And so we did a lot of hard work and like, well, how do you make an EHR that can prescribe something other than medicine? How do you work out these electronic referrals? And so regardless of, us not being able to continue the program and not having huge enrollment, we worked out some of those really tedious and boring parts that can sometimes get in the way of a program being able to launch. And then also just the ongoing collaboration with other community partners. That relationship with American Heart Association was, solidified even more, in our relationship with the county and being able to bring them in because, especially in Precinct 1, where Rodney Ellis is a huge biking proponent, it just created a way to kind of solidify those relationships. So it's not always about like, oh, well, we didn't meet the enrollment numbers or we didn't get to measure A1C and things like that. There are other tangible things that can come out of projects like this. Also, in the same vein, things that we could have done better. If someone goes forward with replicating a process or project like this, I do emphasize the importance of written and formal agreements. Even if you have good working relationships, I will say one thing that I could have done better is making clear what my role was between my professional and my personal life. Again, I'm a social worker, kind of just in the community. My professional is my personal, and I have a good way of balancing that. But if anyone else is going forward, I'd say put that balance in writing, and not just have that balance in your head and thinking that there's a shared understanding with everyone about what that balance is. One thing that we could not control was just the sustainability and financial status of Houston Bike Share. I think it's widely known in the community now. If anyone has visited their website, they did have to close, unfortunately, just this year. I think they formally announced it on their website just a few weeks ago, that they did not have the sustained funding. But the impact of that decision started to happen far before the formal announcement. And so again, if one of your backbone agencies in a partnership, if they go out of business, it's just going to impact the whole thing. Also, even though the American Heart Association granted funds to Houston B-Cycle to subsidize the rides for our patients, Legacy still needed to put a credit card on file just to create the account. And we just couldn't work out the glitches in the financial system and the payment system to always have those charges go through at the time of enrollment. So that became a barrier for patients actually getting their accounts activated. And a lot of times when you're trying to support someone in behavior change, you need to be able to move at the speed that they're ready to move. And so if you say like, okay, we're going to get you enrolled. Oh, but your account can't be activated for another 5 to 7 days. You've lost that momentum. You've lost, whatever passion or fire that doctor was able to put under that patient. You've kind of lost that if you don't have that technology piece worked out on the back end. So overall, we were only able to enroll slightly under 20 patients in the time that the program was running. And, like William already mentioned earlier, part of that was also just not having as much physician support as that we wanted to. And that's not to say that the physicians didn't want to do this, but they're also not incentivized to do non-medical interventions, right? They are paid to click a lot of other buttons that go into HEDIS measures and other things that are being evaluated, but they're not incentivized to make these things a priority, even if they personally have a passion about it and personally they want to do it. So that's just a structural change that is a part of our medical system. I'll turn it back to you, William.
Thank you. So I want to kind of highlight our program as it is today. So right now we have 2 managers, 1 program specialist. We do have 3 community health workers. One of them is working on early childhood interventions, and we do have 2 more who are onboarding, who will support cancer screening and helping our patient population meet that gap in care for anything that's kind of recommended based off their age or other health risk. We do have 30 AmeriCorps members associated with our program and 25 interns. So they are what Felicia shared earlier. They help with our health advocacy. So they help with the program enrollment. they do a little bit of patient education, and then they do that follow-up piece. So it's not just enrolling you in the program and say, hey, good luck. It's like consistent following up every 7 to 10 days to be sure that whatever interventions is recommended or provided, that they're actually able to engage in that. These are our current goals. So a lot of it is related to screening and intervention, but we are working with other like-minded organizations to really help the data infrastructure and coordinating services and aligning existing pathways. And definitely open to establishing other opportunities with anyone else who would like to collaborate with Legacy. Next slide. So I'm going to talk a little bit more about our FoodRx program. So for those who remembered me speaking last December, I talked a little bit about the data side of it, and I got invited back, or we got invited back to kind of highlight where we're at today. We were in the process of transitioning to Epic, and we just had a lot of opportunity to make some revisions and refinement based off the additional data we're able to see. So if you look at our target population, we're targeting pediatric patients who are at the 85th percentile higher, adults who might have a A1C of 5.7. We also are doing hypertension, so patients who might have a 140 over 90 in blood pressure. And then we're also targeting our OB patients. So pretty much any patient who is maybe at risk of have an at-risk pregnancy related to food insecurity, we're able to enroll them into our program. And this is the collaboration with the Houston Food Bank. And the goal is to kind of stabilize or reduce their metrics over the course of 12 months. Next slide. So with our Epic transition, it also kind of aligned with some hard requests from the Houston Food Bank. So one change that happened at the beginning of the year was that we weren't allowed to support neighbors who weren't Legacy patients. So for our mobile distributions, we had to only support people who were Legacy patients who enrolled in our FoodRx program, which was devastating here because we had established a lot of rapport with our neighbors in our regions, and it was hard to kind of turn people away those first couple of mobile markets. The other hard goal that we agreed with the Houston Food Bank is working towards 75% utilization of the program. So of patients enrolled, they would need to visit a food for change market or mobile distribution at least once a month. And so with all this change, we're switching to an EMR, we're enrolling program level data. We are looking at SUH from a universal perspective. So prior to our go live with Epic, we were very program-based with screening. So only people who were enrolled in our, who were health advocates were screening for SUH-related data. But with our new EMR system, it allowed for providers, medical assistants across multiple service lines to screen and engage in the work. So we just got a better sense of the need in our clinic population. Subsequent, we had to really narrow our focus. And so before we were just screening everybody who might be coming in for a well visit, but with that transition to Epic, we really focused on our FoodRx enrollments and making sure anyone who is eligible for FoodRx were getting these kind of wraparound services and supports, which really helped with our data quality. So again, the same thing from our BioRx program, we were considering enrollments, clinician referrals, and utilization. So and I'll show us some data in a few slides, but one big thing was our patient experience when they came to redeem their prescription at our mobile market. There were long wait times, so people might have been waiting 30 minutes to receive food that day. And so we really thought, about like, how can we improve this? And so instead of having patients get out of the car and kind of engaging with the produce that they were picking up, we really switched to a drive-through model. Patient reported that was easier for them because they are trying to get in and out for the day. Like if you think about your own trip to the grocery store, I'm trying to get in and out. I'm not trying to be in the grocery store for 2 hours. So just recognizing that patients, so they want to engage with the food, they also have other things going on as well. And so we tried our best to kind of transition to that. The other big thing that we adjusted was that clinicians said they don't know how to refer. So we came up with this whole referral guide by going slide by slide, screenshot by screenshot by how to refer, because on our end, it looked very simple, straightforward. But from a clinician perspective, there were just a lot of different buttons that they got lost in Epic. And so we came up with a how-to guide to help not only have them complete the referral, but also have Z codes to recommend to associate with that referral. The other big changer was we expanded our target population. So we recognized that clinicians, though they wanted to address, childhood obesity and about A1C pre-diabetic, they also had a large hypertension patient population that we serve here at Legacy, and actually aligned with one of our board goals. Our board goals for our last fiscal year was to get 71% of our patient population with hypertension in controlled. So it kind of aligned nicely. And the other big game changer was we got data directly from the Houston Food Bank about how well we were doing. So pretty much at request or monthly, we were getting data about how well we were doing towards these goals. So which really helped with refinement and adjustment along the way. Next slide. So in that top graphic, you'll see what our data was before beginning of this 2024. So on average, we had about 30 new patients enrolled for the end of our fiscal or beginning of our fiscal year. We had about 52 unique patients coming to redeem their prescription either at a mobile market or at one of the brick and mortar places. And overall, we had about a total of 200 visits during that half. But as we adjusted and made revisions to our workflow and really focused on what we were doing, we saw this huge adjustment to the trend. So going now to 262 new patients enrolled in the program, averaging about 300 unique patients and over 1,000. I think it caps out at so over almost 1,000 people coming to redeem their prescription at any given time. So just this huge adjustment to what we were doing. Next slide. And this kind of how it looks all together. So you see this kind of which was just amazing to kind of experience. Shout out to the Houston Food Bank, Jasmine specifically. She's been a great thought partner, and before her it was Nicole, really providing us that data that kind of help us know we're on the right track, because it was definitely a challenge in the beginning. And so as you can see, our enrollments over the course of that first few months in the 2024. There are some dips in May, just because that's the time of our end of the semester. So many of the interns we had were kind of wrapping up their internship and moving on out of the program. Next slide. The other big game changer, so we had UT Health data from a few years ago that really kind of showcased like, this is what it looks like. This is how you could experience it, but we weren't experiencing it for ourselves because we couldn't see who was in our program, just with our previous EMR. But with our new EMR, we had a student from Rice Community Bridges. She studied our data, and turns out our data was mirroring the UT Health Study data as well, showing that people who were redeeming their prescription more often were having better health outcomes, that hypertension was impacted most with changes to the diet. So people were seeing their blood pressure reduced prior to maybe seeing their A1C reduced. So it also kind of solidified like we're on the right track. And so for those who definitely are looking to evaluate their program but may not have the capacity or the resources to do so, I definitely recommend Community Bridges. Their students are really helpful with that process of evaluating programs. Next slide. Yeah, so future direction. So one thing I wanted to highlight, so we stopped actively enrolling our BioCorrect program when we switched to Epic. So we are in the process, or we have rebranded it to ActiveRx. So this program is meant to not focus on just cycling, but really looking for low cost, free exercise programs in the community. So this could be a like a neighborhood center. This could be a YMCA. This could be Planet Fitness. This could be a park or walking group in someone's community. So really trying to get at the individual level and connect people connected to their community is where we're at. The challenge still is getting that provider engagement. We just haven't had a lot of referrals for ActiveRx. And so we're in the process for this fiscal year figuring that out. So really thinking about what would be a good workflow. Legacy does hire a fitness instructor. We have a fitness specialist on site. So really working with her as well to kind of think about what is the best pathway to kind of generate that buzz around it to help people have better health outcomes. Again, we're looking for additional pathways for closed loop referrals and really trying to increase navigation and reduce barriers to care. And not just care when you think about going to a medical facility, but care also in the community. And I think we're at the end where we're open to questions that people might have.
Great. Thank you. This was really, really interesting. I appreciate this, everybody. So I'm going to ask everybody on the call if they want to start putting questions into the chat. Please do that. I'll go ahead and take a facilitator's privilege and ask at least a question to get us started off on this. And I see a couple people kind of had comments in the chat about this engaging the physicians. So I just want to make sure. So Felicia and William, you talked about the infrastructure that you put in for the prescriptions, right? For the biking or the active thing, and then you also did some other stuff with clinic engagement, and even with this greater, because I totally agree with you, having this infrastructure for physicians to engage and know how to do it. It's boring, it's dull, but it's really kind of the key to it. But even with that, you're still struggling with physician engagement. Can you just talk a little bit about that physician engagement piece?
I can start off, William, if you like. Yeah, so in my experience, physicians are asked to do so many things, and they're incentivized to do so many other things other than this, right? And so, you know, if at Legacy at the time that I was there, the standard clinic appointment was 20 minutes. The physician may have only been in that room for 10 of those minutes. So there's a lot of competition in the conversations that you're asking a physician to have. And so, like I said, even if they want to do the right thing, they oftentimes just don't have the time to do it. And so we went through that process of like, just click this. So we did the 2 referral routes because sometimes they don't have time to click the button right there in the patient's appointment. They're doing their documentation afterwards. So we made it so that like, just give them this piece of paper, this colored piece of paper, and they can, the patient can then walk over to the desk and do their referral. If you just have the conversation, because we feel like every doctor is having that conversation of you need to diet and exercise. So you're doing that anyway, just give them this paper and the patient can take the next step on their own. But then for those that forgot to have the conversation in the room, the physician could then make that e-referral and our health advocates would follow up with the patient on the back end.
Okay. Great,
and so
great.
working with your IT team very closely to figure out that e-referral piece and making it that one click, that's going to be key.
I'm going to circle back to that point in a minute. But I do want to look at Carla's comment and Dr. Gentry's comment. It looks like they're looking for a little bit more clarification. So Carla says that when you refer an Epic, is that referring something like Find Help, or did you create an Epic order for the mobile pantry or a CHF referral? Can either of you? And then Dr. Gentry asks, are patients referred to the Forex program after they're screened for food insecurity? So a little bit more detail on how you do that.
So when we transitioned to Epic, a little bit about our system. So we are a shared system with some other FQHCs in this Southeast region. So we don't share our EMR just with us, we share with some other partners as well. So that's something to kind of clarify. So when we are onboarding, we told them these are all our programs. So they created a program in Epic for us. And so the referral is to that internal, what they consider internal referral within Legacy. So they're clicking for internal referral and then doing a drop down or checkbox for which program they want to refer to.
So this is a referral to a legacy program, right?
Right. And then in that process, in that following up with the patient, we enroll them. So the provider can see that we've enrolled them into the program, but we do that extra step with the Houston Food Bank with submitting their information, like demographic information, for them to be officially in collaboration with the Houston Food Bank. We hope eventually Houston Food Bank would get access to Epic, where it could be a little bit more seamless. We're just not there yet.
Yeah, I hear you. Okay, I have a bunch of other questions, but I want to honor some of the comments on this. So Joshua Collins, I think, is asking an interesting question. Was Greater Youth Health Connect included in the data exchange? And are you being reimbursed via Medicare or Medicaid using your SDOH screening?
Good questions. So Greater Houston Health Connect is not currently actively involved in this process. So we are working on a pilot project in the next several months. And we hopefully that will turn out to be an awesome collaboration. We can see if someone's has medical history outside of our Epic. So we can see if they're like new to Legacy and we're trying to see historical data and we're looking at their A1C from when they went to Harris Health or some other system. So we can do that, which allow for like same day enrollment. So someone trying to establish care at Legacy today, I'm going to be let's enroll you into Food Arcs as well. But you don't have an A1C, it's going to take us a while to get labs. So we can use that historical data from the system to do it. The second question about
Getting money.
Yes. So we, to my knowledge, we are not being reimbursed for this at this time. I think part of it is just working out the state. I know they've instituted some new trainings and things that they are coming online, but currently we're not being reimbursed for our efforts.
I want to give you guys a shout out for using Z codes. And for people who are listening, use your reaction button and give us a reaction if anybody else who are using the Z codes for their NMDOH program. Can anybody just let us know, if anybody's using the Z codes? Those are going to be, at the end of the day, key for getting your money. Right, because those are the codes that MCOs have agreed to, and so connecting your work to those Z codes is really, really smart. So appreciate you for that. That was good. Okay, let's look at Ms. Ramon's comment. What made you decide to use a mobile market versus a brick and mortar for food distribution? And was nutritional education or recipes included in the box?
So. If you haven't been to a Legacy clinic, we know we're short on space. So we just didn't have a space to have a brick and mortar like the Harris Health system. I think they just had bigger space to kind of plan for that. So the mobile market, in part due to the pandemic. So one thing we didn't highlight, but we launched our program during the pandemic. So we had to do it outside with masks and things like that. So that's answered that question. We have seen that our patient population actually chooses our mobile market. I don't know why per se, but when we look at where they're going to redeem it, it's mostly to our mobile market. There is one brick and mortar location in Southwest Houston, Bethel's, that they use a lot. But I think it's just at the convenience of the patient. Felicia, did you want to add anything?
Said it exactly.
Okay.
Yeah, and let me build on that. You know, one of the things that I love about your approach is you're very patient-centered, and you're very community centered. And you talked about how important partnerships are to this work. And somewhere in there, you talked about a brain trust, the creating a brain trust. And I was like, wow, that sounds cool. Who is in your brain trust? A, and B, of the partners, we all like to have partners, but not every partner is the wonderful thing that we would hope them to be. So, in your experience on either one of those programs, who have been not the usual suspect? Of course, Houston Food Bank is going to be an amazing partner, but are there other partners that turn out to be like super useful and amazing? So, A, who is in your brain trust? And how do you use that brain trust? And B, of the sort of not obvious partner, who are the ones that have really shined for you and why?
Talk about starting from the beginning. American Heart Association approached Legacy in wanting to coordinate a COVID response. And so being that we were this, social determinants of health responder in the agency at that time that came to our department. So they started off as even, I wouldn't think of the American Heart Association as wanting to do food interventions, but food health is, heart health, right? So
Right.
it goes together once you think about it. And then at that time, again, this is 2020, I had a close partner, a close relationship, collaboration with someone working in the Fifth Ward Community Redevelopment Center.
Nice.
Sort of one of their incubator, she was within their incubator organization, and they helped us with the food distribution. So they became a part of our brain trust. After that, it grew into, and William can talk about this, people from the American Heart Association branched off into other ventures. And so that's with Fit Houston now. So William, I think they're still in your brain trust with Active RX.
Mm-hmm. They are. Yeah. So I think what I appreciate about some of the people within the brain, they show up consistently. And they're,
Nice.
I think, like people like Larissa who get on the bike with the community and listen. I think that was a game changer. I think it wasn't always about, hey, I want to come in and do a program. I want to hear what's going on in your community. And I think since Legacy already does that well, I think it's always easy to work with someone who's willing to join in our conversations with the community, with our patient population to kind of figure it out, because we have some answers, but the community has the real answers. And so I think
Yeah.
for Larissa and Emily Paul and a few other people to show up and like, hey, I'm listening with you. I don't have the answer. I'm listening to kind of figure out what we can do to support the solution.
Yeah. That's
And I'll
wonderful.
just add, if you're working in communities and you don't know where to start, look up your neighborhood, your super neighborhood organization for your community, or your civic club for the community that you're looking to intervene in. And you're not going to those meetings proposing what you're already going to do. Like, you haven't just worked out these things in your office, in the medical center somewhere, wherever you're based. You're going to these meetings to listen to what they're already doing and what they're already asking for infrastructure support for, and then going back to your ivory tower, your building, to figure out like, well, what resources do I have to lend to what people are already doing? That's where to
Yeah, I
start.
just love that. Love that, Felicia. Thank you.
And I would also
So
add patience as well, because when we had to reduce our distribution to just people enrolled in the program, we had, so at Fifth Ward, if you're familiar, we have a senior living facility right across the street. And a lot of them have been benefiting for just us doing a mobile market. We were actually utilizing the local church parking lot to distribute the food. When we shut it down, they were mad. Yeah, we stood in that sitting and heard that feedback, and we thought about, well, how can we make amends? So we really did some outreach to them. We're trying to help them establish care with Legacy. We try to work out a way for, like, you don't necessarily have to change doctors, but can you establish pharmacy level care with us? Can you meet with our registered dietitian to help create that pathway for you to continue to benefit? And I think right now about 20 of them have been enrolled in the program since that launch. So we really worked out ways to kind of rebuild that trust with that community.
Yeah, that's great. Okay, we need to turn it over to Jackie. Jackie, I'm just going to point out to Ventrice's question, the last question about, I don't know if you want to respond to that, but I also just kind of wanted to say this last statement. We didn't get a chance to talk about it, but the work that you did to create a data infrastructure for regional measurement and evaluation, I want that to be another webinar, team. That one sounds super interesting. It is that next step. And when you think about partnerships, one of the things that I think that I love about you is your IT team. We often are so focused on the program, we don't bring in those internal people. So, as usual, you guys are amazing. Thank you very much. I'll turn it over to Jackie.
Thank you, Jessica. And wow, William and Felicia, thank you so much for sharing your experiences. I especially appreciate your sharing lessons learned and what could have worked better, because I think it's a really great example of the vulnerable leadership that makes this work successful. Thank you, audience, for engaging in a robust discussion. We had some fabulous questions come through. Before signing off, I want to alert you again to our consortium's program index, which many of you have been in touch with me about, and I'm so grateful for. This is a catalog of NMDOH programs across the state that are sponsored by health system organizations like plans, providers, and hospital systems. The index features abstracts of programs with various searchable fields. But the program index is only going to be as robust as we make it. So I'd like to invite you all to contribute to this effort by connecting with me. Just send me an email at jk90@rice.edu and tell me about the programs that you're implementing. Our next learning session will be Thursday, July 18th, Improving Health Through Data, Understanding Your Patient Population Needs to Maximize Impact. Wow, with Dr. Cecilia Ganduglia-Casaban from the Center for Healthcare Data. So please check that out. You don't want to miss it at our driversofhealthtexas.org/events. Thank you again, all of you, for a robust discussion today. We are grateful for your input, and we really want to know your feedback about this webinar. You will receive a short survey from us in the next several days. This consortium is going to be what we make of it, so we look forward to hearing from you. Please stay in touch with us. Again, you can always reach out to me and the rest of our team